Hi, I'm Steve Selig, founder of Fit Test, in part 4 of my 5-part series on the European Society of Cardiology guidelines for exercise for patients with cardiovascular and cardiometabolic disease. In part 4, I'm going to just cover the ESC guidelines as they treat arrhythmias, including atrial fibrillation and atrial and ventricular tachycardias, long QT and Brugada syndrome, and implantable cardioverter defibrillators. And as for the other parts in this series, I'm just letting you know that you can get these guidelines free. They've made it worldwide access to this, full text, pocket guidelines, or even the slide set. So coming to atrial fibrillation, and the first thing I should say is that I've produced many YouTube videos on atrial fibrillation. You can find those by searching for me, Steve Selig, on YouTube. And I recommend those to you in conjunction with this as well. So first of all, atrial fibrillation, I'm just going to cover the red underlined dot points. I should just cover the first one first. Regular physical activity is recommended to prevent atrial fibrillation, and it's also useful for preventing further progression in those with atrial fibrillation, provided they're clinically stable. Atrial fibrillation ablation is recommended in exercising individuals with recurrent symptomatic atrial fibrillation and/or in those who do not want to undergo long-term drug therapy, given its impact on athletic performance. In other words, the ablation will have a positive impact on athletic and exercise performance. The ventricular rate whilst exercising with atrial fibrillation, that is those who have not had ablation reversion back to sinus rhythm, but are in long-term or permanent atrial fibrillation, the ventricular rate for these clients should be considered in every exercising individual by symptoms and/or by ECG monitoring, and titrated rate control should be instituted. So really what this means is you have to work with a client and the primary care medical practitioners and even the cardiologist in getting rate control at the right level to make exercise both enjoyable and safe. Carbo-tricuspid isthmus ablation should be considered in those. So that's a right-sided ablation, as opposed to the normal pulmonary vein isolation techniques that are used for atrial fibrillation. So this right-sided ablation should be considered in those with documented atrial flutter who want to engage in intensity of exercise in order to prevent atrial flutter with one-to-one atrioventricular conduction. Now, what that means is if you've got one-to-one atrioventricular conduction, it means atrial rate in flutter is up to 300, and that would come through in a one-to-one transmission rate into the ventricles, and it would expose the ventricles to extremely high, in fact, unsustainable, very high ventricular response rate. So that's why that ablation should be considered. Now, this again just underlines the importance of you and your client working closely with the medical practitioners and particularly the cardiologists. The bottom dot point there, the use of class 1 antiarrhythmics as monotherapy without proof of adequate rate control for atrial fibrillation or atrial flutter during vigorous exercise is not recommended. So again, that needs to, and that's an example of that drug is flecainide. So that needs to be, again, the partnership between you as the exercise professional, the client, and the treating medical practitioners is really needed to address this point. Sports with direct bodily contact or prone to trauma are not recommended in exercising individuals with atrial fibrillation who are anticoagulated. So this is people in permanent AF who require anticoagulation for the reasons I've given extensively in my YouTube videos on atrial fibrillation. So please go to those. I've talked about that extensively. So we don't want these clients who are involved with direct body contact type sports or prone to trauma, for example, skiing, not recommended in exercising individuals with atrial fibrillation who are being anticoagulated long term. SVTs or supraventricular tachycardias, ablation of the accessory pathway is recommended in competitive and recreational athletes with pre-excitation syndromes such as Wolff-Parkinson-White, who also have documented arrhythmias. So they do better if they've had those accessory pathways ablated. There are lots of examples. And again, I've produced YouTube videos on SVTs and VTs. And again, you can search for me on YouTube for those videos. In competitive or professional athletes with asymptomatic pre-excitation, an exercise physiology study is recommended to evaluate the risk for sudden death. In competitive athletes with paroxysmal supraventricular tachycardias, but without pre-excitation, curative treatment by ablation should be considered. And among individuals with frequent premature ventricular contractions or VEs and non-sustained ventricular tachy, a thorough investigation with Holter, 12-lead ECG, exercise testing, and suitable imaging is recommended. So again, you, the exercise professional, working with your client and the primary care medical practitioners. Long QT, I've just sort of pulled off the internet here, a stylized ECG of long QT, and the numbers are shown here, but you can get a lot of that information also within the guidelines, but also by other reading. It is recommended that all exercising individuals with long QT syndrome with prior symptoms or prolonged QTC, that is adjusted for heart rate QT, be on therapy with beta blockers at target dose. So you're looking for people with long QT being on beta blockers to protect against those dangerous tachyarrhythmias and tachycardias that can come with this condition. Shared decision-making should be considered regarding sports participation in patients with genotype positive but phenotype negative long QT syndrome. That is less than 470, so not the really dramatic long QT, less than 470 milliseconds for QT in men, less than 480 milliseconds in women. Participation in high-intensity recreational and competitive sports, even when on the primary treatment of beta blockers, is not recommended in individuals with a QT longer than 500 milliseconds or genetically confirmed long QT with a QT, corrected QT of more than 470 in men and more than 480 in women. So here again, we have this example of staying away from one of those favorite interventions of high intensity interval training. Stay away from it in people in this situation who have whether or not they're on beta blockers, but where they've got a very prolonged QT or genetically confirmed long QT with between 470 and 500 for men, or 480 and 500 for women. Participation in competitive sports with or without an implantable cardioverter defibrillator is not recommended in individuals with long QT syndrome who have had prior cardiac arrest or arrhythmic syncope. So this is really saying that be very, very careful if you're going to apply either competitive sports, which obviously often involves high intensity exercise, but even high intensity recreational exercise, you've got to be super careful in applying that exercise and in fact avoiding it. Now, the levels of evidence are at level 3 for these, so that's not recommended. It could be harmful. In terms of high intensity recreational exercise, the level of the quality of evidence is B, that is single randomized clinical trial or large observational studies. And it's only, whereas for competitive sports, the quality of evidence is at C, that is expert opinion. Brugada syndrome, I've highlighted in red border all of these dot points, and without sort of laboring on it, because you can stop the video and read them all, I'll just try and quickly go through them. So implantable cardioverter defibrillator implantation is recommended in patients with Brugada syndrome with episodes of arrhythmic syncope and or survival from sudden cardiac death. I should have just said on ECG, the Brugada, at least the most common form of Brugada, is coved ST segment in the anterior V leads. So you can see here this coving here going way above baseline is the characteristic ST, and Brugada is an ion channelopathy. Following implantation of an ICD, resumption of leisure or competitive sport should be considered after shared decision-making in individuals who have not experienced recurrent arrhythmias over 3 months following the ICD implantation. In asymptomatic individuals with Brugada, asymptomatic mutation carriers, and asymptomatic athletes with only an inducible ECG pattern, such as this, participation in sports activities that are not associated with an increase in core temperature may be considered. So the issue with increasing core temperature is that can produce an exacerbation of the ion channelopathy, which can produce some of the potential for sudden cardiac death. So you've got to be very careful here with Brugada that they're not engaging in super endurance events that can produce big increases in core temperature or exercising in hot and humid conditions. Prescription of drugs that may aggravate Brugada, electrolyte abnormalities, and sports practice that increase core temperature above 39 are not recommended in individuals with overt Brugada or phenotypically negative mutation carriers. Now, finally, implantable cardioverter defibrillators I've already been talking about. Holter recordings and device interrogation during and after resuming sports should be considered to allow appropriate tailoring of rate-responsive pacing parameters, exclusion of myopotential or electromagnetic inhibition, and detection of ventricular arrhythmias. Now, what this really means is you as an exercise professional need to know what the settings are, what the tachycardia programming is, and also the defibrillation programming, the limits are on those devices, so that you stay well under the tachycardia settings and obviously the defibrillation settings, and that will very much limit what you're going to do in terms of your exercise programming. An ICD or implantable cardioverter defibrillator is not recommended as a substitute for disease-related decision-making when looking at sports participation. So the way I interpret that sentence there is that just because someone's got an ICD in their chest does not mean that you as an exercise professional can just go to sleep in terms of what you're instituting for your client. You still need to look at the disease-related recommendations and look at an ICD as an add-on therapy rather than a definite savior of preservation of life-preserving technology in all situations. That's not what you should be doing. You start off with disease-related recommendations for that client, and the ICD is an added advantage, an added bit of safety to your exercise intervention. These are the references that I've used to put these series of videos together. Thank you for watching this video. And as always, you can contact me with questions or queries or requests for what you'd like covered. info@myfittest.com.au, and have a great day. Bye for now.